So we want to welcome you to this mentoring session today as we talk about some issues in GYN pathology. I'm going to turn the time to Dana and Kamalji to conduct and call upon some of your mentors to uh, make presentations or bring up cases. And if need be, I have a few cases to share also.
Good morning. So Minnie has a lecture that that is very popular with her residents, going over endometrium, which is such a tricky topic. I think we'll end up doing cervix next time, since I think cervix was on the menu for this morning, but we're going to jump into endometrium, and Minnie has volunteered to share that lecture with us. I'm excited because I also am starting to sign up Gyne, and I'm also going through this module with you all. So we're learning together.
Exciting. Okay, so let's see. So this is a lecture that I gave to our residents. It covers all the basics. So whatever, it might be a nice review of the real simple stuff. But I think it's always refreshing. I know when I was putting it together, it really helped me remind myself of the pathology, and then I started looking at cases differently. So I think it's always a nice review. Okay. So just to start, and how much time should let's see. Oh, yeah, we have a little bit of time to do it. So, for normal endometrium, sort of think of it in two different layers, two overarching layers. There's the superficial functionalis, also called the stratum spongiosum.
Vinny, do you want
Yeah.
to share as a slideshow your PowerPoint
Yeah. Can I
work?
do that? Let's see. I don't know how to do it from Google Slides.
What about if you click on something called slideshow? Would that be a good view?
You have it?
Underneath on
Yeah.
your right side top.
Does that work for you guys? Are
It's
you
loading.
able?
It's
Okay.
getting there.
Okay. It says my screen sharing is paused on my end when I
Oh,
do it this way.
it says it's loading on this side. I see.
Okay. Yeah. I
Maybe
think
not.
yeah,
Oh,
maybe. Yeah, I don't know if it lets me do it from
okay.
this way.
Even
Mm,
if you click on the upper right corner besides your P initial, the slideshow.
this
No,
way.
the next, no, go. It's a
Um,
slide, a P, and then the star looking thing, share, and then slideshow.
1 second.
That's okay.
This. Yeah,
Oh, I,
think.
but that's the one that's causing you to
Yeah,
pause. I
yeah,
see. I see. Okay.
yeah. I'll keep it
Sorry
this way.
about that.
That's okay. Is it we tried. We tried it. Um, is it big enough? I guess that's the only other thing I could try to do that. Yeah. Um, so the functionalis is the layer that responds to hormones, either external hormones or internal normal cycle hormones. And within that, the endometrial glands, they're pretty regularly spaced. They're also perpendicular to the basalis surface. And I'll show you a photo of this so we get to sort of appreciate that. But the glands that are down in that basalis area, they look a little bit different than what we normally, when we talk about proliferative and secretory and all of those endometrium glands. These glands are a little bit more inactive appearing at baseline. And then there's spiral arteries that have thick muscular walls within there, and the stroma is quite cellular, and that's what makes up the basalis. And then moving down a little bit lower, that's what abuts the myometrium, and it regenerates the functionalis after shedding. So during reproductive years, this cycle undergoes morphologic changes, and that's what we're capturing when we look at biopsies or curettages, is what phase it's in. And we're really looking at that superficial 2/3, that functionalis layer, when we're evaluating these samples. So just to give a visual of, you have the myometrium down here, and then you have that basal layer where it's a little bit more cellular stroma and active glands. thickened vessels, and then the functional layer, which is what we're really evaluating and looking at. So then in terms of just the vascular supply to this area, it originates all from the radial arteries that are coming from that underlying myometrium. And then these give rise to basal arteries, which then divide. So you have horizontal branches that go into the basalis, and then you have vertical branches that spike up into the functionalis. And then these are what we think of as spiral arteries. That's what we call them. So normal endometrium, you have glands and you have stroma. The glands are usually tall columnar. They can be ciliated, have microvilli. That's normal. You can see here there's a ciliated surface to it. It doesn't have to always have that. And then the stroma is filled with these plump spindle cells that have scant cytoplasm to them. And the changes that during the cycle affect both stroma and glands. And there's a specific set of changes within each that sort of dictates where you are in the cycle. And then the pathology comes in when things are out of sync with what we would expect them to be or normally be. And so this just gives a nice little overview of seeing that all put together with the basalis, where you can see much more cellular stroma. It's a lot bluer in between the spaces of the glands, and they're a bit smaller. And then as we move up, you have a lot of spreading out between the glands, more stroma that's sparse, and the glands are pretty well spaced out and spread out. So we can sample the endometrium with a lot of different ways. We can do curettage, we can do biopsies, sometimes even polypectomies if there's a polyp, just to remove that. And the indications are numerous. The most common that we see are abnormal uterine bleeding or postmenopausal bleeding, sometimes it's called. But you can we'll also get samples for when they've done an evacuation after a missed abortion or spontaneous abortion. Sometimes clinicians will send samples to assess response to hormone therapy. And in the practice of fertility workup, maybe even endometrial dating. So just a sort of caveat to endometrial dating, I'm curious about how much you guys have seen this in your institutions. It is generally, there is a high inter-observer variability with it. So it's something that we do, but to just know that it's not always practiced everywhere. And a lot of times accurate dating won't be possible because of either polyps or endometritis, or the patient has a intrauterine device for birth control or for managing bleeding. So there's a lot of things that sort of get in the way with determining accurate endometrial dating. And this really, at least in my practice, I would only give it if the clinician's requesting for it. Then that's a reason to look for it. So the normal cycle, just a little brief overview. I want to get more into the morphology later, but it can range anywhere from 24 to 35 days. The proliferative phase is the one that varies. So secretory is constant, it's 14 days from ovulation to menstruation, but proliferative is what causes that range, as well as the duration of flow itself, because that can range as well. And then with each of these, you have the changes in the hormone spikes, and then that's what it's the withdrawal of the hormones that triggers that menstruation. So we start day one, we always say, is the menstrual phase, and then we move into proliferative, and then at the midway mark, that 16-day endometrium is a term sometimes used, and then into secretory, and then back into the cycle of shedding. And what I'm going to go over next is what changes we kind of normally see in these different phases. There is a table here, and I can actually this is in the um, lecture module, but I can also include it as like an addendum in some way to get this to you guys. So we don't have to like zoom in on this. We're going to talk about this later, but just to look at the different layers and what's happening in each. So starting with day 1 menstrual phase, this is what happens when there's an absence of implantation. So what is actually happening is the degeneration of that corpus luteum, which was built up by the hormones to prepare for implantation. And when that doesn't happen, you have complete degeneration of that corpus luteum due to the cessation of estrogen and progesterone. And that decline in those hormones will initiate this spasmodic like constriction of the arterioles, and then the shedding happens, and that's collapse of both stroma and the glands that were in that functionalis layer. And then the pre-decidualized cells will also condense into aggregates and cord-like arrangements. So you might see in a biopsy at this time, you might see a lot of blood and acute and mixed inflammation. And these are all normal things that you would see during a menstrual phase on a biopsy. So, for example, in here, you see lots of blood, all these red blood cells, but we're also seeing scattered mixed inflammation throughout, and you get these dense pre-decidualized aggregates that form almost like cords. And this would be a shedding endometrium. Here's another example of it. You can also see these stromal balls, sometimes we call them. They're just very dense aggregates of the stroma. And you can see some inflammation floating throughout here as well. So another case, we talked about the stromal balls. You'll see strips of just shedding endometrium, the inflammation, and then you can also appreciate apoptotic bodies. And this is just the degeneration. So it's more of that picture that's happening. So then moving into the proliferative endometrium. So this is where the endometrium is starting to build up after it's been shed. Now it's starting to regenerate, and it typically lasts 14 days. And this is where we see the thickness in the endometrium. So sometimes you'll get like on the clinical report, it'll say, or in the requisition form, it'll say she has a thickened endometrial stripe, and that's, typically it's above 5 millimeters, and that's why they're submitting, because if it gets too thick, then that's worrisome for an underlying process. And then within proliferative, we like to divide it into different phases. So in proliferative, the overall picture, if you're looking at like low power, is the glands are rounded. They're, we're looking at them at cross section, but they're like little donuts. If you get them at a tangential, then you might see like a long strip like that, but you're looking for glands that are both rounded and then straight-ish strips. And there's a lot of space between the glands. That's a good thing. When the space starts to get smaller and smaller between the glands, then you're worrying about the abnormal pathology. So again, straight, they're not coiled, so they're not rounded, or they're not tortuous glands. They're very straight, and they'll look like circles when they're in cross section. They also have this pseudo-stratified epithelium, which means at the base, you'll see the base is all the nuclei lined up at the base. But then when you look in the top, sometimes it looks like they're kind of stratifying on each other because the way the nuclei kind of grow and sit there. But as long as the base has that single layer of nuclei, then that's pseudostratified. You also look for mitotic activity, both in the stroma, so out here, and then within the glands themselves. And those are the features to really look for in early proliferative endometrium. And as you move more towards, you get later and later into the cycle, now the glands will start to get increasingly tortuous. And it's a spectrum. You're moving towards secretory where they're incredibly tortuous, and we'll see what that looks like. You also have a loss of cytoplasm as you move later in the phase, and the nuclei get more oval and elongated with, you could sometimes even see prominent nucleoli. And then there's this interval period. This is that day 16. Sometimes it's sort of that like in between, you'll see both. You'll see maybe some of the features of proliferative, but then you'll start to see some of these other features that we're going to talk about in secretory. So when you sort of look at a biopsy and it has a little bit of both, can't quite place it, they might be in that interval phase. So secretory phase, you can appreciate like how tortuous these are compared to the nice straight glands that we see in proliferative. And then the stroma in between, it's also really, there's a lot of white, there's a lot of empty space in there. And it gets very edematous. That's what's causing that space between the glands. So this is a very classic feature to remember for secretory, is these subnuclear vacuoles, and it creates little white spaces. So the nucleus, this is the base on this end, the nucleus gets pushed into the apex towards the lumen, and you have these vacuoles here, and people call it looks like piano keys, if anybody plays piano. And you could even get this is where the secretions are happening. And then as we move later, the secretions will start to build and fill into even the glands themselves, like we can see here. So this is at the peak secretory phase, where we have a very tortuous gland filled with secretions. And this is more of that, just to get an appreciation of both the space, that edema between them, and then the glands look really, they're not straight at all. They have all these little indentations within them. That's the tortuosity. Okay. And then right before you start cycling again, you go into a predecidual phase. And this is really where the changes are seen more in the stroma than anything else. The stroma starts to look very plump. The cells themselves will take on, they might have a more pink cytoplasm to them. And then you might get stromal condensation around. So these are your spiral arteries, these little rounded guys with vessels or red blood cells in them. The stroma will start to condense around these vessels or these arteries. And then that's basically the way I think about it is that's where the blood supply is. And so those stromal cells want to really prepare themselves for that implantation. So they're going to aggregate around the arteries. And then that when the implantation doesn't happen, then it goes into shedding. We repeat the whole thing all over again. So I want to just go over normal IHC, very minimal, that we see within the endometrium. We don't use it terribly often. It's more if we have a biopsy and we're not sure if we're looking at endometrium or endocervix, sometimes they can look similar. So sometimes stains help that way. Or if we're entertaining like an entirely different cancer from somewhere else, it can also be helpful. So normal endometrium is going to be ER/PR positive, estrogen and progesterone. And it's in both the glands and the stroma. So it's a nice baseline. The glands are going to be CK7 positive and CK20 negative. So that sometimes helps with, sometimes we consider GI tumors can mimic, or endometrial and GI tumors can sometimes look like each other. So if we're trying to distinguish between those, that can be helpful. And then the stroma, this is, I think, a nice one to use, is the stroma is CD10 positive in the endometrium. So this is great for if you are looking to see if there's endometriosis sometimes. With endometriosis, you need to have both glands and stroma present to be considered endometriosis. So CD10 can help tell you whether there is true endometrial stroma there. I want to check in on time. I can keep going. I just have a few more basic pathologies that we see, but I can also stop here. Let's go into Dana.
I think you've got time to go ahead. We'll go
Going?
into breakout rooms in a few minutes, and then people can
Okay.
ask questions and stuff. But I
Perfect.
think we have more time.
Okay, wonderful. So some common pathologies that we see. First is the endometrial polyp. And this is probably one of the more common things that we see. To diagnose an endometrial polyp, you need 3 features. And these all 3 have to be there to call it a true endometrial polyp. If they're not there, you have 2 of them and not 3, then I like to say features of an endometrial polyp, or features suggestive of endometrial polyp. So the 3 features are you have to have dilated glands. So this would be an example of dilated glands compared to the normal strip here. You have to have stromal fibrosis, which is in here, there's a little bit of basically the stroma will start to look a little bit more pink and fibrotic. And then, as we can appreciate here, thickened artery walls. So they have to appear thicker than the normal 1 or 2 layer that they typically have. So all 3 features need to be present for that. Another thing that we commonly will get asked to evaluate is chronic endometritis. And this is the importance of this really is to determine if we do make this diagnosis that the patient's going to then get put on antibiotics for treatment. This is commonly, you'll see this in the setting of fertility testing. Sometimes if a woman has been trying for a while and is unable to, sometimes the culprit is chronic endometritis, and just treating that helps resolve the issue. So what we look for in chronic endometritis is the definition is if you see a plasma cell in the endometrium, you only need 1. You can use CD138 as an immunostain to detect these plasma cells, but typically it's not needed. You'll see the plasma cell, and I like to I don't kill myself. I was taught that spend 5 minutes if you suspect chronic endometritis, spend 5 minutes looking at high power. And if you don't find it then, and you really do suspect it, then you can do the stain. Or it's just not there, because 5 minutes should be enough time of really looking carefully at this slide. So, but what sort of tips me off about whether I should look at that high power for 5 minutes is if I see a tissue culture appearance at low power. So what that would look like is there's kind of like it's almost like that secretory edematous look in terms of sparsed out white stroma, but then the actual stromal cells will have these points to them. They look like fibroblasts in a tissue culture. So very pointed ends. When I see things like that, that's when I will go high power and look for the plasma cells. Another thing that we might see is disordered proliferative endometrium. And this is a diagnosis I like to use it's when, as opposed to something like hyperplasia, which we'll talk about later, disordered proliferative is the entire endometrium, the entire sample you're getting looks abnormal. And it looks abnormal in that you have dilated glands that have mitotic activity like proliferative, but it's everywhere. So it's sort of like a change to the overall endometrium, as opposed to hyperplasia or carcinoma, where those are focal entities, or polyp, things like that. Disorders, the entire thing is taking this on. Another thing that we'll see is especially here, we have a lot of breast cancer patients are on tamoxifen, and it looks like an endometrial polyp because it has these dilated glands, but they're really it has that Swiss cheese appearance, which we think of as like these large punched out holes. That's what that Swiss cheese appearance refers to. You can also get staghorn shaped glands like these, which are like angulated glands. And then you can have proliferation common in these polyps within the stroma and the glands. I think I have, yeah. Another thing is this pseudo deciddualization. So this is what I was talking about, where you get these really plump decidualized cells that are very pink. This pseudo decidualization, so decidualization's when you're referring to it in the context of pregnancy. The pseudo is when it takes the effect, the appearance of it, but it's in the setting of the woman's getting exogenous hormone treatment. So progesterone, to stop bleeding or things like that. So it's not actually in the setting of pregnancy, but it looks like the cells do when you're pregnant. And then just some pitfalls. So this is something called a telescope artifact, and this can sometimes be concerning and mimic carcinoma or hyperplasia because the glands look more crowded than they ought to be. And this is just caused by these glands are moving around, and they can sort of invaginate on each other and form a telescope of glands. So the glands themselves aren't growing in a crowded manner. They're just smushed together artifactually by the way we process the biopsies. The Aria Stella is another pitfall. Like if I were to, especially as a first year, if I were to look at this, I would jump straight to cancer because it's very worrisome. The glands are so crowded, and they're forming these like pseudopapillary structures, and the nuclei look really bizarre and atypical. And these are all features that we think about when we think about cancer. And in the endometrium, this is like one of the caveats is when you see this, just pause and think, okay, how old is this patient? Is she on any hormone, or is she trying to get pregnant? Could she be pregnant? And this isn't cancer. This is actually just associated with the reaction of the endometrium to pregnancy, or the effect of progesterone sometimes to an extreme degree, I guess. So it's really it's the presence of chorionic tissue that triggers this reaction. And then metaplasia. There's so many different types of metaplasia. I'm just going to show some nice examples so you see them. But what causes metaplasia is a change in hormones from what is baseline. So either high estrogen related to if the patient has PCOS, or if they have cancer, or if they're receiving exogenous treatment. IUD can do it, and chronic endometritis can also trigger it. So squamous metaplasia, or squamous morular metaplasia, sometimes as we like to call it, is one thing that we see. This is associated. So this is not directly indicative of cancer, but it is seen associated with cancer. So if we see these squamous morules, it is important to comment on them. It doesn't mean that the patient has to go straight to hysterectomy. It just means that maybe she needs a little bit closer follow-up than you would have normally given. And then another is tubal metaplasia. So like I said, the cilia is, normally it's not always present, but when you get very clear ciliated, this mimics the fallopian tube lining, then that would be tubal metaplasia. Another one that's a little bit scary sometimes is this papillary syncytial metaplasia. This is what's occurring when you're in that breakdown process in the beginning during that menstrual phase. And you could really have it at any point if there is a degenerative breakdown happening. to the endometrium, and you'll get little tufts of these clusters. They can have mitotic figures. They can look very scary, sometimes looking like different cancers, and that's where either stains or seeing other features of breakdown would help you differentiate between, is this a benign or a malignant process? And that is all I have for lecture slide. So I'm going to stop share now.
So I suspect people have some questions, but why don't we move into breakout rooms and then you can ask those questions in a smaller group setting. So I've got 2 rooms and I've assigned everyone to a room. So let's reconvene there.
We have Dr. Hassel.
I have a question to start off to the real GYN pathologist in the room. This this institution, if you call it that, because Quest, but our Tampa group has a cutoff of 5 plasma cells to call chronic endometritis. What's your experience with that? Is it an arbitrary number? Is there data behind that?
I think for me, I kind of moved away from like definitely signing out chronic endometritis because I don't know what the patient's on, and sometimes it could be IUD. But I always report even if I find one, and I try to quantify in my diagnostic line, like in the comments, and then to say clinical correlation recommended. If I do, like Minnie mentioned, if I see subtle changes in the stroma, I try really look for plasma cells. Um, I mean, if it's like really obvious, then I'll put it and say chronic endometritis. But if it's like very rare, that's what I tend to do. What do you do, Dr. Hassel?
Yeah, I was trained with the one plasma cell is sufficient, but as you say, there are other besides infection, there are other things that can set up a chronic endometritis. But I don't differentiate those. I just kind of report what I see. But another feature that I think is helpful to me is if I'm in a situation where I'm having a difficult time deciding, is this proliferative? Is this secretory? I mean, if I'm having a difficult time dating the endometrium, that to me is another indication that I need to look and make sure that there isn't chronic endometritis going on, because typically that interferes with the normal hormonal cycle.
I always find there's sometimes in between phases that you have both. And I try to go by the most, like majority of glands or what they do. Because the physiological state is always kind of fluctuating and it's a spectrum. So I also encounter like those difficult phases where you can't really have a distinct cutoff. But yeah.
Thanks, guys. That's very helpful. And I think just to point out to the trainees that this concept of this is how you learn pathology. You constantly talk to other people. How are they doing it? What's your cutoff? What are your signs? How do you report it? So, you kind of grow up in your training institute and you think it's done one way in the way that you're trained. And then you come out and you go into a new practice and they're doing it a different way than you learned. At Stanford, they stained every single case and they counted every single plasma cell and they reported it as a number. And that was mostly driven by the clinical team's request. So yeah, that's something I wish I had known in training, that concept that pathology as there are a lot of black and white guidelines and cutoffs, but there's a lot of gray area too. And it's about what your practice is doing and what your clinicians want and, what your population is too.
Yeah, when I trained for my fellowship, they told me not to stain for CD10. I mean, I'm sorry, not CD10, the plasma cells.
Yeah.
Mm,
Oh, yeah.
yeah. Because then it's sometimes non-specific. If you can't see it in H&E, then it's not worth staining. Yeah, that's what I've been taught. And yeah, there's so like you always really have to adjust to your clinicians, what you are, and yeah, try to absorb what we are doing as a group in pathology. I'd like to ask you guys, what do you guys do in your programs? Like, since you guys are in residency and training, how have you been modeled with your attendings and what did they have told you to do? Anyone?
Also, on the same note, I'd love to hear what kind of specimens are you
Mm,
seeing? Is it mostly biopsies, cancer resections, benign uterus, cervical, PAPs, no PAPs?
Can I pick Billy? What do you do in your practice or when you see your endometrial specimen?
I often see the cytology specimen. If there are some atypical features,
Mhm.
people tend to do a colonoscopy
Mm.
uh, to detect the lesion, and then people try to biopsy the lesion. In my practice, I didn't see the cone biopsy. Uh, if there are some lesion, the clinician will discuss with the pathologist whether they remove only the entire uterine with or without the ovarian, or just do some uh, mm, uh, yeah, that the specimen that I think that I meet, and I didn't see the cone biopsy in my real practice.
So you see mostly cervical lesions than endometrial.
uh, yes.
I see.
So one thing to be aware of
Mhm.
is that there's a very big difference demographically between the population that we see in the United States and the population that you're often dealing with in Southeast Asia.
Mhm.
Because the average body mass index, the obesity trend has been going on in the United States for 50 years. But I have noticed in my travels in Southeast Asia that the body mass index is gradually creeping up now as economics and peace have made more calories available for people. And so I think you will begin to see over the course of your careers the greater presence of that risk factor in women, leading to more problems with abnormal bleeding and so forth, due to hyperplasias or the early development of cancers. And so that's probably a reason why you don't see a lot of endometrial biopsies for abnormal bleeding, because it's not as common there due to the relative lower body mass.
Yeah. I saw a study when I was preparing for a different talk. Asia has the highest increase over like 20 years of increase in endometrial cancer frequency. It's yeah.
Yeah.
So let's see. I do have few slides if you guys want to take a look and we can maybe have you guys to guess what kind of phase we're in or what kind of problem or would you want to do that or should we just if,
I
okay.
see some heads nodding. Yeah, that would be helpful.
Okay.
Uh, Before Dr. Esther sharing the slides, I want to ask the question that I always thinking about when we have a case that for me, I even don't know the answer. There are any suggest any step that I would follow to find out the answer?
Yeah, so the first step is, I think, to make sure you know the the question or the history of the patient as much as you can. Find out why the biopsy was done, what the symptoms were, what the age is, and other background. Um, and then that's where you start showing the slide to other colleagues to see if they have ideas or suggestions. Um, and then you begin to formulate a differential diagnosis. You know, could this be a metaplasia? Could this be a funny polyp? Could it be neoplasm? Could it be a metastasis or something of that sort? Um, and as you then develop your differential diagnosis, that's when you start to say, okay, what would help me to differentiate, you know, diagnosis A from diagnosis B? What would help me to tell the difference there? Is there a stain? Is there more history or something of that sort that would help me to solve that? Um, and that usually will get you very close to the right category of disease or circumstance. And then if you need a little help, then maybe you send it to a more, you know, famous consultant or someone who specializes in that particular problem to get their opinion. But really, very often, if you just allow, you know, find out more about the patient and more about the setting, that will lead you in the right direction. When I was a trainee, we used to say that if you listen to the patient long enough, they will eventually tell you the diagnosis. And I think that's true with a slide too. If you study it long enough, you will eventually come to the right kind of differential and answer. Of course, if you've never seen something, it's maybe harder, but even then, I have found the circumstance where something that I saw long ago or read about last week or something will eventually tie into the case as it is discussed and as we study the slide.
And also sometimes I sort of look at the radiology note or clinician note, they have a differential. So that's feel like my starting point to look into it if I have no idea. So, all right, so let me share. Okay. So I like everybody who's willing to answer. Tell me what kind of specimen this might be. And this is very low power. This is lowest I can go. And you can just unmute yourself and shout out what kind of specimen, whether it's a surgical specimen from hysterectomy or, I guess, another specimen.
I think this specimen is the endometrial curetex.
Yes. So it's some kind of curettage. It's not a whole intact surgical specimen because you see strips and fragments. And you can sometimes you can like see elongated long shape of where your curettage tool probably went in. So now in low power, what are some characteristic of stroma versus and glands you see? And this, I think it's really a textbook picture that we saw in Dr. Mini's presentation also. So I'm pointing to some hints here.
I think the glands here are very dilated and angulated.
Yeah, very good. Dilated and angulated, those are the perfect words. And what are these pink stuff in your dilated and angulated glands? Just secretion. It's very, yeah, I was just maybe a tricky question, but secretion of your angulated and dilated glands. So this is a secretory phase of your endometrium, right? And you can see the glands are going from probably here was a basal eyelids and going all the way to the top of the surface. And you can see the stroma, some areas with white spaces in between, and the nuclei are far away, so it's kind of edematous. And some areas, and this is what Dr. Minnie was saying, kind of artifactually telescoping in fragmented areas. So it often happens with curettage because you're just kind of going not blindly, but you're trying to get as much sample as you can and kind of scraping. So you have some disorganized glands and fragments here. Um, and you have congested blood vessels. And there was an area that kind of, to me, suggestive of polyp. Um, so here, it doesn't really have all the blood vessels, but the shape has the polypoid architecture with a 3D dimensional area where it's surrounded by all this epithelial, the glands. And the stroma hasn't really responded compared to the surrounding. So could be a little bit of suggestive of polyp that's not responding the same way. Let's see. So that's a classic secretory endometrium. Again, oh, sorry, this is a surgical specimen. So we have the myometrium, and then we have our function, the secretory top functionalis layer here. So we have the elongated, long, tortuous glands going all the way to the top and the secretion. And then we see kind of contrasting, inactive, small, rounded glands at the bottom, this junction to where your endometrium and myometrium meets. So this is a full section of hysterectomy specimen going from myometrium, your basal layer, and all the way to the surface with some hemorrhage. So you start seeing condensation of stroma or hemorrhage whether, let's see. And here we have some pseudo or some changes in your arterioles, in spiral arteries. Sorry. Another one. Again, all secretory glands here. I think sometimes metaplasia, when it's like really extensive, can be difficult. And when you have so much secretory glands, it's one of the challenging things to distinguish is this hypoplasia versus just really full-blown exuberant secretory glands. I think Dr. Hassel has a good lecture on YouTube about that. And let me show you this case. So we're kind of going into abnormal pathology now. So this was a specimen for abnormal bleeding. And I have the hysterectomy specimen, and this is a shave of your endometrium, because sometimes when we're going into next phase, next topic, but when we're examining endometrium, if you can't process all endometrial glands, we do shaves. I don't know if that's a similar practice in where you are. So this is just strips, short strips of endometrium and a little bit of myometrium junction. But when we're examining endometrium, so most, we want to rule out if there's cancer or precancerous lesions. So most common is endometrioid type, and precursor lesion will be hyperplasia, so increase in number of glands. So hopefully you can see in low power, we have some crowded glands. Some are getting really back to back, some irregular, some dilated glands. So this is getting into hypoplasia. Here's more. This is at the surface here. So you shouldn't have this many rounded glands on the surface, theoretically, if you're normal, I guess, like a better word. But you can see concentrated glands in this field here. So we are always assessing the ratio between the stroma and glands. And this is something called endometrial hypoplasia. And then now you can try to assess if there's any atypia in cytology or complexity in architecture. But that's more to come for next time. I think that's what we're going to talk about, malignancies and precursor lesions. But I just wanted to show you some slides I had prepared. Do you have any questions?
Yeah, I have one question.
Mm-hmm.
How do we say that the gland to stroma ratio is greater than 3:1? Because at least in my eyes, I only see these glands are more crowded than the normal glands, but I don't know. Is it crowded enough or not?
Particular case, yes. This case is crowded. So we see, I think it's a threshold you're gonna build also, and depending on what phase it's in, like it can have a little bit of crowded and increase in number of glands when you have a secretory phase. Because there was a proliferative phase to have more glands, and now you have secretory that's really a lot more glands than your baseline. But in this particular case I'm showing here, none of these are secretory glands, right? These are very nice, rounded, tubule-looking glands. And going in high power, these two glands are almost touching. There's maybe one or two stromal cells in between. So that's kind of a good indicator to assess also. If it's not a secretory glands and if you have nice rounded glands and there's minimal stroma in between, then it's probably hypoplasia. I don't know if that answers your question.
You mean that we will see the stroma between two glands? If it less stroma there, that would be crowded.
So yes. So gland to stromal ratio, it's 1:1. That's what the textbooks usually say. So when you have sort of an equal distance and you have a room in between, like there's some stroma cells in between the glands, that's okay. But when you're starting to see most of glands don't have stroma in between, like this one, maybe one gland or maybe a fused gland, there's like maybe two or three cells, it's back-to-back glands, then you're in a hypoplasia realm.
Yeah.
Yeah.
Thank you.
And
Thank you
sort of
so
an
much.
interesting backdrop on this. when Dr. Nucci and her colleagues at Brigham and Women's were developing the the new definitions of hyperplasia under the name endometrial intraepithelial neoplasia. One of her guiding principles was reproducibility, and she decided, and I remember her speaking about this, that if her 10-year-old daughter could tell that the glands were crowded versus not, then that was a pretty good criterion. That an inexperienced observer looking at something could say, "Oh, this is not normal. This is crowded, or this is different than the background glands." That would be a much more reproducible criterion. And so that's I think what Esther's been trying to say here is you have to be able to, quite simply see that it looks different, and therefore it's not going to be normal. And of course that's helpful. You're helped in that if you've got an area of good normal or more normal appearing gland to stroma ratio to compare it with. Sometimes you have that, but sometimes you don't, and then it's a little bit harder.
Right. Oh, did you have a hand up?
Yes. Professor, can I ask one question? How to different between the atypical hyperplasia endometrium with without hyperplasia? How to different?
Oh,
One
so
hyperplasia, one no plasia. No, atypical hyperplasia, one another two without atypical. How to different about gland and the stromas.
So let me confirm your question is how to differentiate hypoplasia and
Yes,
atypical hypoplasia?
yes.
Oh, okay. So I was taught 4 different tiers, but it might not be well reproducible, like Dr. Hassel said. But now atypical hypoplasia is in the EIN category, and anything that's not EIN, endometrial intraepithelial neoplasm, it's considered simple hypoplasia without atypia. So when you're looking at atypia, we're looking at cytologic, the nuclear shape and morphology. But EIN, atypical hypoplasia, can include the cytologic atypia and complexity of gland architecture. Yeah.
Thank you.
Oh, you're welcome.
Yeah, always look to see if you have a clearly normal area to compare with in your sample. And if you can look at those glands and say they look much less concerning than these other ones, then you're likely more towards the atypical category.
Oh, here. So these 2 glands, even in this power, looks a little lighter, little larger nuclei than compared to here, right? It stands out. So this would be atypical hypoplasia because of the cytologic change compared to the surrounding. Yeah. Does that make sense? So if
There will be some more practice slides to practice that skill in the module as you study through the materials that we have in the online material.
I'll stop sharing. It's at 9:08. So when are we meeting again? In 2 weeks?
Thanks everyone for participating, asking good questions. And please, if you're able to or want to present a case, don't hesitate to contact us so that we can help you prepare for next time.
Sounds good. Great. Thank you. Have a good evening, night, day,
Pro,
morning.
Thank
Prof,
you.
Professor Esther, can I next presentation?
Oh,
If I don't have a slide, how can I make the slide presentation? I don't have a cache or slide, whole slide scanner.
I mean, we can